So let me, first things first, with the light, can you all see that screen okay? Yes. You're all okay with it? I was told to sit. I've never given a talk sitting down.
Irl, if you want to be standing, that's perfect.
Well, you know what? I think you know what? It's not so much I'm comfortable. I think you may hear me better. And I'm going to move over here. And you know, I let Jenna know that I was coming down today. I'm actually doing grand rounds at Stanford tomorrow, and it isn't a coincidence either. If anybody looks at your sports calendars, the Huskies play the Cardinals tomorrow night. And so there's real reason for that. I appreciate the introduction from Jenna, who I've known. How long have I known you, Jenna?
Decade and a half.
It's been a long time. I was just talking to somebody about Mindscape and Harold Goldberg.
Oh, yeah?
Remember Harold?
I do.
We go way back together. But this has been a topic on biomarkers that has fascinated me for years. And just by way of introduction, at the University of Missouri, I started medical school, now I'm going to really date myself, in 1980. And we just started using hemoglobin A1C, and I was actually working with one of my mentors as a medical student. He's now retired, but his name is David Goldstein, and he was one of the people who really figured out, both from a clinical point of view and a biochemical point of view, how to use hemoglobin A1C. So I've been interested in this topic literally since we started using it in 1980. Okay, I pressed for the first slide. It worked a few minutes ago, Manny. Let's see if it works. There we go. So, you know, this is our gold standard. And the question is, okay, this is our gold standard. How precise is this assay? Because understanding, and probably everybody in the room knows that we talk about precision as the degree which repeated measurements under unchanged conditions show the same results. So we do a test over and over, and if it's precise, we get the same result. And there's something called NGSP, which stands for National Glycohemoglobin Standardization Program, and they tell us, this international body tells us that the precision should have a coefficient of variation not more than 3%. So that means that if a patient has an A1C of 7%, the variability from that assay should be 0.2%. Now this is going to become important when we talk about what these A1Cs really mean. And for somebody with an A1C of 10%, that means the variability can't be by more than 0.3%. That's what A1C, when you have a good assay, that's what it's supposed to be. And the question is, with A1Cs as we measure it now, are they precise? And the answer is, if you compare 1993, which wasn't that long ago, and now you look at 2014, what you see is, in 2014, the A1Cs really are precise. So I can see a hemoglobin A1C assay done at UCSF or at Stanford, and I can look at it at the University of Washington from our assay, and I can tell you those tests are actually pretty good. So at least we can compare one lab to another, whereas even a decade ago, we really couldn't do that very well. So that's point number one. And we've known going back 35 years how A1C is made, how we have glycation to the hemoglobin molecule, and we've actually been using hemoglobin A1C as our most fundamental research and clinical endpoint for the past 3.5 decades. Does anybody know when hemoglobin A1C was actually discovered? What year? It was shown that people with diabetes had this variant in their hemoglobin, and it came off when they eluted the hemoglobin, and it was called hemoglobin A1C, and was higher in people with diabetes. That was 1968. Nobody knew what it meant, but we've had this really since 1968. It was used clinically in the early 1980s. So the question is it all that simple? We can bind glucose to hemoglobin, we can measure A1C. Is there any reason to challenge this accepted dogma? And I would say, folks, we got it all wrong. This was a study called the ADAG study. We were actually one of the 11 sites in the study at the University of Washington. And what we did was, we used an early version of the Medtronic sensor. We put it on patients for 3 consecutive months, 3 days for 3 consecutive months. And in fact, this study was so important that many labs right now use this data when hemoglobin A1C is reported. So you see for hemoglobin A1C of 7 that the estimated average glucose is 154. And many labs in the US today, when the A1C comes back at 7.0, it will say that the average glucose is 154. And for those of you in the room with diabetes, maybe you see that. An A1C of 9, it means the average glucose is 212. It's based on this study with a very primitive sensor by current standards, and that's the way it was supposed to be. But what was in this paper, which nobody paid attention to at the time, and there was nothing in the discussion of this paper, which is almost 10 years old now, is the 95% confidence intervals about what these A1Cs mean. Now, you have to understand, to get in the study, there could be no kidney disease, no liver disease, no anemia. And in fact, the reticulocyte count had to be normal. The reticulocyte count is a blood test we do to see if the bone marrow is making more red blood cells than normal. Even that had to be normal. So this is as good as it gets in terms of looking at a population that really has nothing else going on with their hemoglobin. And what this means is that if you have a patient with an A1C of 7, the average glucose on the CGM could range from 123 to 185. Or if you have an A1C of 9, that average glucose could be anywhere between 170 and 249. That's a big window. What I'm telling you is, if you look at Manny and you look at Jenna, Manny could have an average glucose of 180 and an A1C of 7. Jenna could have an average glucose of 175 and an A1C of 9. Jenna has a higher A1C but a lower glucose when you look at her blood sugars. Did you know that? Did you know what a discrepancy is? Because everyone glycates hemoglobin differently, and everyone's red blood cells live at a different rate. So these A1Cs, we can compare them within the same person. So if Manny's A1C goes from 7 to 7.5, I know that the blood sugar is higher on average, but I have no idea what that glucose level is because there is so much variability in the population. So one can't compare the A1Cs between two people. Can't do it. So then we did another study. This was the JDRF sensor study, and we saw the same thing. The first author, by the way, was Darrell Wilson at Stanford. But look at the A1Cs of 7. Look at the A1Cs of 8. Look at the huge amount of overlap. And then, by the way, we have a few people who are way outside and are outliers. So here's somebody who has an average glucose of CGM of 210, yet their A1C is about 6.5. With an A1C of 210, here's somebody else with an A1C of 8 and an average glucose of 135. No kidney disease, no liver disease, no anemia. It's all over the map. Yet, this blood test, called the hemoglobin A1C, is how we decide to tell a woman it's safe for her to get pregnant, or how we decide a doctor is not doing a good job and we pay or don't pay the doctor based on this test. Is that right? That's our current system, folks. This data, Annals of Internal Medicine, 2017, Roy Beck, Rich Bergenstahl. What the real point of the study was to look at how African Americans glycate differently than Caucasians. And what was shown is that with an A1C of 8, no matter what the ethnicity, you can have a glucose range from 120 to 210 if the A1C is 8. 120 to 210. Now, if you have an average glucose of 210, you may say, well, we need to do insulin therapy, but you can have an A1C with an A1C that high of 7.5%, and there's no way you would start that patient on insulin with type 2 diabetes. We have this all wrong. So what they then did in another study is they looked at 4 studies together, almost 600 people, and compared that to the study that we did a decade ago. And what you see is the data are the same. And you can have an A1C of 8, and the average glucose levels are actually almost identical between the two different studies. But look at an A1C of 7. Again, you see somebody with a very high glucose level can have a higher average glucose than somebody even with an A1C of 9. The A1C doesn't really tell you about the blood sugars. It gives you an average, but it only gives you an average for that person. What does all this mean? In the best of circumstances, there's wide variability in hemoglobin A1C from person to person. And it gets worse when you start adding things like kidney disease and liver disease and anemia. This is due to differences in glycation rates, that is, how glucose binds to proteins, in this case hemoglobin, and the red blood cell survival. It's not the same for all of us. So the good news is, unless one develops an anemia, requires a blood transfusion, or some other major change in red blood cell kinetics, one's A1C should be stable for each individual over their life expectancy, but that's if you're a man, not if you're a woman. Okay, where am I going with this? Well, the reason for that has to do with iron. And I can't even read this. You are sharing your screen. Why do women have to be more skeptical about their hemoglobin A1C test? Well, in the US Census from 2010, there are 112, almost 113 million women between the ages of 18 and 44. 10% of these women, over 11 million in this population, are iron deficient. And 5% of them are anemic. So you have women in this age group of childbearing age that are anemic or iron deficient. What does that have to do with hemoglobin A1C? Turns out it has a lot to do with it. If we look at somebody with an iron deficiency anemia, these are patients with type 1 diabetes. Type 1 diabetes with anemia. The anemia is treated, the blood sugars are no different, yet you just treat the iron deficiency, the A1C goes from 10.6 to 8.3. By treating iron deficiency, you can lower the A1C. And by the same token, you take people without diabetes and you treat their anemia with iron, you can cure their diabetes. They didn't have diabetes to begin with. The point is, if you're iron deficient, the A1C is going to read falsely high. Now, if you're a woman and you're trying to decide if you want to get pregnant or not, I would argue you need to know this. Because if you're anemic from iron deficiency, your A1C is going to read high. Most of the things causes the A1C to read low. This causes it to read high. So, you know, I show this to the residents in Seattle. This is a 44-year-old man with type 1 diabetes, end-stage renal disease, wearing a pump with Lispro or Humalog. The other medications is what we typically give patients with kidney disease: furosemide, amlodipine, calcitriol, carvedilol, EPO, and aspirin. The A1C is 6.2. And, you know, I go through this. What should we do with this A1C of 6.2? The bottom line is we can't make any conclusions. And there are several reasons for it, the big one being the erythropoietin we use in kidney disease. What the erythropoietin does is that it stimulates red blood cell production from the bone marrow, and the A1Cs read low. They're actually all over the place, but here you see that with an average of 150, you have an A1C of 6 instead of 7. It lowers the A1C on average by about a point for people who take this medicine for their anemia of kidney disease. The A1C means nothing, yet this is what people do. This is why the nephrologist thinks diabetes is so easy. Everyone has low A1Cs. Well, that's because they're giving them a medicine that lowers the A1C. So what we've known for 35 years is there are many reasons A1Cs may be falsely measured to be low. Variants of hemoglobin, decreased red blood cell survival, even certain drugs may interfere with the assay. And by the way, we're not as smart as we think we are. This was a study from Portland from 1963. I actually went back in our library. This study was published the month before President Kennedy was assassinated. That's how old this study is. Turns out it's a really important study because it was looking at red blood cell survival in people with aortic stenosis, people with mitral valve prolapse, patients who had aortic valve replacements, a very common thing that happens in our older population. And the bottom line is it reduces the red blood cell survival by 25%. This is why I want to listen to see if they have a heart murmur. If a patient with diabetes has a heart murmur, there is a very good chance their red blood cell survival will be low and will be shorter. And the reason is, every time the heart pumps, there's a shearing of those red cells. They don't live 90 days with every heartbeat. And as those red cells are sheared, that means the bone marrow has to catch up and make more red blood cells and make them faster. So the red blood cell survival is shortened by 25%. Guess what? Their A1C is going to read falsely low. I kind of have to know that. The average endocrinologist, I don't think, knows that. It's really important if somebody has a congenital aortic stenosis. So, what factors A1C, each one with a different rate? Well, red blood cell, making the red blood cells from the bone marrow. That actually is pretty much the same in everybody, but then it makes hemoglobin, and we bind the hemoglobin to glucose. That is different, and we now know it's different also not just between people, but ethnicities in general have different glycation rates, and the way red blood cell is destroyed in the spleen. And by the way, anybody with liver disease or anybody with a big spleen, red blood cell survival is going to be short, A1C is going to be low. Anybody with a big spleen. So the biggest crisis in the US, I listen to the radio driving into work every morning, it's low testosterone. Low testosterone. I hear commercial after commercial. I really do. I hear this, that we need to be treating everybody with we need to treat all men with fatigue with testosterone. Well, all these men come in on testosterone, and what does that do to hemoglobin A1C? Well, I want to thank Manny in advance for posing for this next picture. What happens with red blood cell mass and exogenous testosterone? Manny, thank you for this. It was very nice when we give testosterone, what we can do. But what happens is when you give the shots, sorry, Manny, it was too easy. When you give the shots, you get an increase in the red blood cell mass. But when you use the creams, the testosterone patches, you don't change the red blood cell mass. You get an erythrocytosis, too many red blood cells with the shots. You have a bigger surface area for the glucose to bind to. You get a false elevation in hemoglobin A1C. You can give somebody diabetes if you're using hemoglobin A1C as the metric to diagnose diabetes if they're on testosterone injections. Thank you in advance. Appreciate it. So then that begs the question, what do we know of all the things that alters hemoglobin A1C? And as it turns out, it's huge. There's a lot of things. And we've looked at this twice in our clinic. And to be fair, we have a specialty clinic with a lot of people coming in who are sick with other things, including a lot of people from the Fred Hutchinson Cancer Research Center. We see a lot of bone marrow transplant patients. But nevertheless, in our clinic, up to a quarter of our patients, the A1C doesn't work. It doesn't work because they have one of these things that really mess it up. I think this is important. So my take on this is it's still the gold standard of diabetes control. For the majority of patients, it still does accurately reflect overall control, and it does match well with the ADAC study and the JDRF study that I showed you. However, as a gold standard, I would argue that the hemoglobin A1C has serious limitations. Furthermore, there are many reasons clinicians need to understand why it will not work well for certain common clinical situations, and there are a lot of them. It works best when addressing glycemic control for a population, a clinical trial. So if you're testing a new drug and the A1C goes down by 1.2%, that's real. And because when you're looking at a population, the A1C is really good. But when I'm looking at an individual and I don't have glucose data, whether from fingerstick glucose or CGM, I don't know what that A1C means. Here's another typical case study. It's a woman, she returns after bypass surgery for new coronary arteries. Lab test performed the day before her appointment shows her A1C is 5.8. She's on big doses of glargine and Humalog. She denies hypoglycemia. What do you know, and I give this to the residents and I give this to the fellows. She has an A1C of 5.8 what everyone wants to do is to decrease the insulin. And that's the wrong answer. Why is it the wrong answer? Well, she had a surgery that more likely than not, she had to have a blood transfusion. You're measuring somebody else's hemoglobin because that surgery is commonly associated with blood transfusions. So you have to know that. Here's another case. This is a 52-year-old woman with type 2 diabetes. She's on glargine and 3 oral agents. Her A1C is consistently in the mid-7s, but her meter is downloaded. Doing 3 tests a day, her average is 220 to 240 on her meter. She doesn't have an anemia. Her reticulocyte count is normal. She has normal kidney function. She has normal liver function. And so, due to the discrepancy, a fructosamine is ordered. Raise your hand if you've heard of fructosamine. Raise your hand if you haven't heard of it. Most of you haven't. Okay, so this is important. This is another blood test that we do. We frequently do it as an alternative to hemoglobin A1C. And I measure it, and it's 399. Well, what does that mean? Well, fructosamine is another blood test that we do when we're not sure if the hemoglobin A1C makes sense. We've had this for decades, and it's just glucose binding onto protein, and the most common protein used in fructosamine is albumin. But fructosamine, another blood test, also has a lot of limitations. First of all, as opposed to the 90-day or so red blood cell survival, fructosamine is a glycemic history of 21 days, because that's about how long albumin lives. The relationship between glucose and fructosamine, we know it's not a straight line. And as opposed to A1C, with fructosamine, we don't have continuous glucose monitoring data, and we don't know how it corresponds to complications like we do with hemoglobin A1C. And there are all these things that mess up the fructosamine, including high bilirubin, high uric acid, high protein turnover. And by the way, if somebody has a low albumin, like almost all kidney disease patients do, this test is going to read falsely low. So that's problematic. So the main concern with this test is that it needs to be corrected for albumin, and we do that in our research studies, but when we order this, it is not done. We just get a fructosamine, and the fructosamine has to stand by itself. So let's go back to our patient. I can go online, and if I Google fructosamine A1C comparison, I get this graph. And this table is actually pretty good. And let's go back to our patient. Her fructosamine was 399. Her mean finger sticks on her download was 235. And that actually is pretty good. The two correlate very well. Her fructosamine is about 400. Her average glucose on her download is about 240, 235. They correlate quite well. But when we look at our patient, that means her A1C should be about 10. And in actuality, her A1C was 7.6. So it's way off. And I've been doing this in my head, not even knowing it, for over 20 years. Asking myself, when I download the finger stick glucose levels, or I download now the CGM, does it correlate with the A1C? This lady is way off. And what I can tell you is, this is not uncommon. It's very common, and what the fructosamine does is it tells me that this lady's A1C, quote unquote, doesn't work, or she has a glycation gap. I know that. I know that because her fructosamine reads high. So from a practical point of view, what am I going to do with this patient? Well, from a practical point of view, I'm going to use the fructosamine as the biomarker. Actually, the more important biomarker is the glucose, but I'm still going to measure the A1C. Why am I measuring the A1C? Because that's what I get graded by. Because if I don't measure it, it's going to go on the lab that I'm a bad doctor. Because the insurance companies are watching me, the University of Washington is watching me, I've got to keep measuring it even though I don't use it, because that's what's happened to medicine in this country. It makes no sense. But that's what I do because I know her A1C doesn't work. I do this every single day. Why are you all laughing? This is how you practice medicine now. This is what happens when you know too much. So, it's reasonable to assess A1C and fructosamine, but appreciate that the A1C and maybe even the fructosamine should only be compared for with that patient. For many patients, the key metric to assess control remains downloading of the glucose meter or the CGM. In fact, I would say that while A1C provides an objective measure and should continue to be measured, including for those with a glycation gap, these downloads continue to better assess specifics of glucose control, assuming you have enough data. And I would say for fingerstick glucose testing, you really need 3 tests a day, in my opinion, to really know, does the A1C make sense for that patient? So here's sort of the bottom line. The way I look at diabetes, I'm a simple guy. I went to a state school. Glucose, that's the 3D structure of glucose, trumps hemoglobin A1C. It does. I am more interested in the blood glucose readings than the hemoglobin A1C readings because that's what causes the complications. It's not the A1C, it's the blood sugar. Remember, hemoglobin A1C is simply a biomarker. The enemy is glucose, not hemoglobin A1C. Okay? Really important point, and I think a really important point for what you guys do here at Livongo. Now, wait a minute. For those patients with a glycation gap, especially those where the A1C reads higher than the blood sugar levels or the fructosamine, how do I deal with the performance metrics from our accountable care organizations? Because they're grading me, and they see these A1Cs that are high, and now I'm a bad doctor. And by the way, this is how we're now getting paid. If I see a patient in the Boeing Accountable Care Organization in Seattle or with Microsoft, and the A1C now is above 9, I get paid less. I don't even care about the A1C. I care about the glucose. But this is how we have brainwashed the payers and the companies, and I don't think it's a good thing. This is the stuff that drives me crazy. This is my reaction every day in clinic when I see these patients. That's me. That's me. Because I don't care that the A1C is high if it's a lady with iron deficiency anemia. Or it's a high A1C when I have a glucose download with an average glucose of 138. I don't care about the A1C. So, in the near future, we're going to have glycated albumin. It's measuring just the glycation on the albumin, and it's less impacted by anemia, by kidney disease, or any confounding condition. Outcome studies limited, but initial data suggests higher levels associated with more mortality and hospitalization, but we're just not where we need to be with prospective clinical outcome studies. And just announced about 2 weeks ago, this company in Japan, we're going to have it got the FDA approval about 2 weeks ago. So this is going to be in our labs next year. So you're going to hear more about glycated albumin, and we'll be using it a lot more. And glycated albumin correlates very well with hemoglobin A1C. These were data published from the DCCT group. So the last biomarker, glycomark. Raise your hand if you've heard of glycomark. Just Jenna. Manny, you don't know of this one?
Gosh, yes.
Manny, here, let me give this to you. You can tell us about glycomark. No? This is actually a fun one. I like this one. If you really want to impress your friends, 1,5-anhydroglutatol. It is a sugar alcohol that's in our diet. We all have it in our blood. And what normally happens is that when glucose comes into the kidney, the 1,5-AG is reabsorbed into the blood by this fructose mannose active transporter. And as it turns out, nobody knew this when this was first seen, but this fructose mannose active transporter is one of the SGLT transporters. It's SGLT4. You've heard of the SGLT2 inhibitors that we treat type 2 diabetes with. This is actually SGLT4. And so this transporter brings the glucose back in. So somebody without diabetes, this 1,5-anhydroglutatol, also called glycomark, the glucose is not lost in the urine, but it's actually brought back into the body through this transporter. And therefore, when you measure the glycomark in the blood, since it's not lost in the urine, it's high. Normal level is about 10. But if you have somebody with diabetes and the whole system is overrun, and this SGLT4 can't reabsorb all of this sugar alcohol, so it ends up in the urine. So somebody with diabetes, the amount of glycomark, or 1,5-anhydroglucitol, in the blood turns out to be quite low. Now, most of us lose glucose in the urine with a blood sugar of about 180. Turns out there's quite a bit of variability to that, as there is with everything. But somebody with a very low 1,5-anhydroglucitol is going to have a lot of blood sugars above 180. And the way the company originally marketed this was that it was a way to look at glucose variability. But a better way to look at this, it's the amount of time you're above a glucose of about 180. That's what glycomark really measures at the end of the day. The problem is, if you have somebody with really high blood sugars, an A1C above 8, give or take, you're always losing glucose in your urine, and it's not going to be as good of a test. On the other hand, higher A1C levels reduce 1,5's ability to assess glycemic control. So it's not good if you have really high blood sugars, but it's a way to look at variability. It's a way to, another metric to look at glucose for people with blood sugars that are not that high. And so I mentioned that it's SGLT4 and not SGLT2. And I actually asked the question, if somebody is on a drug like canagliflozin, which is Invokana, should it have a difference? And I was told by the company that makes it, it shouldn't have a difference because it's a different transporter. But they went and they did the study, and as it turned out, if you are on the Invokana, it completely trashes the 1,5-AG in the blood. So if you're on an SGLT2 inhibitor, this test doesn't work. But like fructosamine, there's no randomized controlled trials assessing glycomark and diabetes complications. But where we have become really interested, and in fact we sent an abstract in yesterday to the Endocrine Society, is looking at this test in pregnancy. Turns out in pregnancy, this is a very powerful test. This was our first study looking at 100 women who were pregnant, type 1s, type 2s, and women with gestational diabetes. And the bottom line is, if the glycomark level was less than 6, the neonatal birth weight was abnormally high. And it makes sense because you have these high blood sugars after eating. We know postprandial hyperglycemia is dangerous in pregnancy. And I will tell you, this data is less than a week old, and we got it in for the abstract for Endocrine Society. We had 400 pregnant women, and what we showed, and this is really important, we showed that this level of 6 also predicted whether the woman would need a C-section or whether she would develop preeclampsia. We've also showed that it predicts neonatal hypoglycemia. So this turns out to be really important in pregnancy. And I think we're going to have to get the word out on this one. So this is where we are. We have A1C, which gives us the longest duration for a biomarker. We then have fructosamine and glycated albumin, which is 3 weeks or so. Glycomark, 1,5-AG, is only a couple of weeks. And then we have blood sugar, which I would still maintain is the most important marker of them all, because that's the one that's causing the problem. Remember, when A1C was discovered and then developed in the early 1980s, there was no finger stick glucose testing, or it was just starting. And all we thought we needed was A1C. I arrived at the University of Washington in 1990, and my first debate was with a very famous family practice physician who told me in 1990, nobody was going to stick their fingers for blood sugar testing. It was a waste of time, whether you took insulin or not, whether you had type 1 diabetes or not. And it was not only a waste of time, but a waste of money. And then in 1997, I went to Olympia, the state capital of Washington, for the Diabetes Cost Reduction Act, representing the American Diabetes Association, because there were a lot of people out there fighting against getting glucose test strips for patients who take insulin, let alone everybody with diabetes. And in 1997, the state of Washington made it a law that Medicaid patients had access to finger stick glucose testing. It was 1997. So we're not going back a long way. So to summarize, A1C is far from perfect. Many conditions interfere with its accuracy. A1C levels cannot be compared between individuals. And for some people, the A1C does not reflect the mean glucose consistent with large populations of patients, and the reasons for this are not known. Still, the A1C is our best and only biomarker that both provides a history of glycemic control and has been tested through randomized controlled trials to document the strong relationships between glucose and complications. Clinicians have the responsibility to understand if A1C accurately reflects mean glycemia, and ideally, if not, why not? And then become more dependent on fructosamine and soon glycated albumin and home blood glucose data to make treatment decisions. It's wrong to make a decision on what to do with diabetes on A1C. You need to know the glucose. If I'm going to add another drug in somebody not on insulin with type 2 diabetes, don't I want to know the glucose levels? Because if somebody has an A1C of 7, yet their average glucose is 200, I'm going to add a drug. If somebody has an A1C of 8 and they have an average glucose of 130, not only do I not want to add the drug, it actually may be dangerous if I'm going to add bedtime insulin to that patient. You got to know the glucose. Knowing the A1C is not enough. For those with type 2 diabetes who perform little, if any, glucose monitoring, CGM should allow us to practice in a less A1C-centric environment. I could say you could do the same with glucose testing if you get enough glucose testing in these patients who don't take insulin. It's time to treat the glucose and not the A1C. And up until now, for the last 30 years, that's not how we've been practicing diabetes, not only in the United States, but around the world. In my final slide, I'd like to give this talk to the medical director of every accountable care organization in the United States. They need to know that our A1C has limitations. It's not infallible. So with that, I thank you for the invitation and be happy to take your questions. Thank you very much. Go ahead.
I'm just really interested in knowing, like, what do you do when you see a patient in a clinic where they have a glycation gap that their A1C is higher than their like mean glucose sugar, right?
Mm-hmm.
Because you said like they pay you for the A1C value, but their mean sugars say something else. So like, how do you handle that whole situation? It sounds like
So for those of you on the other side, the question was, how do I deal with the situation when I have somebody with a high A1C, but their glucose download shows that they're doing well, whether it's finger sticks or CGM? I still measure the A1C. I don't pay that much attention to it. I will measure fructosamine. I measure glycomark. But here's something very cool. I have a resident right now who's doing a project with me, a research project. And what she's doing is she's looking at finger stick glucose readings from our patients. And she's going to look and actually show how the finger sticks in our patients, if they have at least 3 a day, correspond to the glucose levels. We're going to show the relationship, how it compares to the study from 10 years ago. And we're going to take it to the Washington State insurers and to the insurance commissioner. So for these patients, what I want to do, if they have 3 tests a day, I can use this instead of the A1C, especially in those patients where I know the A1C doesn't work. She's already gone through 1,500 charts. I don't know if we're going to have data available for ADA next year, but watch it, because this really is important. And your question is very important. Yeah. Yeah, so the question had to do is how do we incentivize doctors to look at the data to begin with? It's easy to get them to look at their Fidelity website every day or twice a day, but how do we get them to look at their patient's blood glucose data? There's several parts to this. On the endocrine side, it's not that hard. When the doctors, the fellows train with us, and they spend 2 or 3 years with us, and then they go out into practice, and they find out that they don't have an infrastructure, and it's really hard for them to do it, they fight for it, and eventually they get it. But that's a tiny, tiny number of doctors compared to especially the primary care doctors, where they don't have the time, they're not interested, and they don't get paid for it. So they don't know if their patient has a glycation gap. All they know is the A1C is 8.5, and they need to watch their diet better, or they need to do something. Maybe we're going to add another drug for the type 2 patient. I believe that it has to be done with passive uploading. You can't ask the doctor to do any more. So here's the ideal situation. Whether it's from the CGM device or the meter, the data is uploaded to the doctor, not in between visits. The doctor is not interested, nor does the doctor have the time in between visits. But the data is uploaded somewhere to the cloud, and then when that patient comes in, or maybe that day. So what happens with me right now, we use Epic, and I know when I come in that all the data is pushed into the patient for that day, all the lab, all the x-ray, all everything. But that data is automatically there for that patient. So when I open up the media tab, I see that data, which is actually a real-time data that comes to my EMR. So the most I have to do is I have to make one click, one click where I'm already there anyway. And you know, if somebody calls in between, they're sick, they're getting put on steroids, they're going into the hospital, whatever it is, if that is automatically coming into my EMR where I don't have to do all of these different acrobatic events to try to get to that data, going through different levels of passwords, going through different clouds, going through different EMR, I don't want that. I want it to come directly to my EMR. Now, what we do in our clinic isn't a fair comparison because we take more time with our patients. Do I think that we are smarter than the endocrinologists that we trained or other endocrinologists in the community? We're not smarter. What we do differently is we spend more time with the patient. And in general, the endocrinologist spends more time than the primary care doctors. What data do I have to show that? You can't make statements like I'm making unless I have data. There was a study done literally with stopwatches published about a decade ago in the Archives of Family Medicine. And they looked at all the different disease states where family medicine docs see. Coronary disease, osteoporosis, diabetes, hypertension, everything. And what was found was that when you look at diabetes, the average family medicine doc spends 20 minutes with that patient with diabetes per year. Per year. They get 20 minutes per year, whether they see them twice or whether they see them 10 times through the year. These family practice docs, well-intentioned, get 20 minutes a year. But that's not the interesting part of the study. The diabetes was twice as much as they spent on coronary artery disease, which is how they're going to die. They had twice as much time for diabetes. So you're right. And in fact, now, we just started this July of this year at the University of Washington. We are now looked at under RVUs, relative value units. And if you are below where you're supposed to be with your RVUs, the chairman is going to write to you or then talk to you that you're not seeing enough patients and you're not seeing them fast enough. This has never happened in our academic institution. Now we are under the gun, just like the private practice guys. I'm still spending time with patients.
So I'm going to stop with questions only because we are at our time, but thank you.
Okay,
very much,
thank you.
Dr. Hirsch.